Hey, welcome to the latest edition of Phoenix Children's Live. I'm your host, Senior Brand Manager Peter Ballestori, and today we're going to be talking about movement disorders and rehabilitation. And with me is the Division Chief of Physical Medicine and Rehabilitation, Dr. Laura Wilner. Thank you for joining us today.
Happy to be here.
Thank you. All right, so before we start, as we always say, let us know you're out there. Give us a like, give us a love. And also, if you have questions, Dr. Wilner can answer them live today. Otherwise, we can answer them afterwards, so feel free to put them in the comments down at the bottom there, and we will get to them as soon as we can if you don't ask it live. So with that going forward, I always like to start off with, I don't think, Dr. Wilner, you've done one of these before. So,
I haven't.
Okay, so this is new for you.
New.
So let's talk a little bit about yourself. What you do here, and kind of what do you head up in terms of your position here at Phoenix Children's?
Sure. Well, I'm the Division Chief for Physical Medicine and Rehabilitation. So I'm a trained physiatrist. So I specialize in working with children and adolescents who have either congenital or acquired disabilities, with some specialization in working with therapy teams, both inpatient and outpatient. And I've been here at Phoenix Children's Hospital for about a year and a half.
Okay.
And we continue to see both patients in the hospital as well as in the outpatient area.
Excellent. Well, welcome to you then.
Thank you.
Okay, so let's talk about the program here. So it's the Francis McClellan Rehabilitation Program. So this is specifically for pediatrics here, and that's pretty different than for the whole Southwest region, or for at least for the state, rather.
It is. It's very unique for the state. We have the only inpatient rehabilitation program in the whole southwest area here outside of California. So we serve a population not only throughout Arizona, but parts of western Texas and New Mexico and Nevada as well.
All over. Yeah, that's great. So when we look on the site and it says it's a comprehensive program, talk a little bit about that. What does that mean to a family that's looking into what our service is here, and it says comprehensive or multidisciplinary? Kind of what does that mean to a family that's looking into using our services?
So for a comprehensive program, what we really like to see is that we're addressing the needs of the patient and family across the spectrum. So it's not just about going to physical therapy or occupational therapy, but having some of the other services, particularly on the inpatient side. So social work services, school teacher services, to talk about school reintegration. Specialists and allied health professionals who know children and know adolescents, and that is what their passion is. So that's part of being comprehensive. And multidisciplinary throughout PCH is working together with other specialists. So many children with disabilities require more than one physician, and what we're really trying to do is pull that together so that orthopedics, rehabilitation, neurosurgery, neurology are all working together on behalf of children and families.
And when you say, so we're very specific to pediatrics, and you say for schoolwork, that's amazing because, maybe it's not typical to have a time frame attached to it, but children can be here for quite a while, and schoolwork continues on. So that's pretty amazing that we offer that. Kind of what is the gamut of ages that we typically see maybe?
So on the inpatient unit, we see children anywhere from 2 or 3 years of age up through age 18 or 19, particularly if they're still in high school. So school is vocation for children. That's their job. In adult rehab programs, we might have work counselors, back to work vocational specialists. But in the children's world, the idea is to get back home with family, back to school, and back to the routine. So the school teacher support is paramount in helping us to do that.
That's great. And you mentioned social workers. Can you give a background on how they would work into that situation?
Sure. Our social workers are quick to identify what resources families might need, particularly if they're facing a new disability, and understanding where they might get help on an outpatient basis to meet the needs of traveling to and from therapy services or special home care services that are needed, so that as we're putting together the discharge plan from our inpatient program, we make sure that all those services are in place.
And I knew I put a question towards the end of this, but I think it works perfectly in. So we talk about how we align with local and national groups, organizations, research, advocacy. Is that kind of that whole world where it doesn't just stop here, it kind of moves outside, and we're working with those types of groups that I just mentioned? How does that work?
Well, we're always striving to make better connections with some of the community support groups.
Mm-hmm.
So it starts with social workers and case managers who may make referrals to local agencies and support groups. Physicians here are trying to have a better relationship with organizations such as the United Cerebral Palsy and other groups that have supported families and children for many years in the Valley. And we also work collaboratively nationally with organizations to promote research.
Mm-hmm.
So the one in particular is our CP Research Network, which is something that we're trying to collect information about children long term so that we can give parents a better idea of what to expect and what interventions are best for a given patient.
When they get that initial diagnosis, right?
Right.
Yeah, okay. So when we talk about our program, how many beds do we have at this point for the unit, basically?
So the inpatient rehab unit is 12 beds,
Okay.
and it's in a specific location in the hospital, adjacent to therapy and gym space,
Mm-hmm.
so that patients don't have to travel very far to get the therapy services that they need.
Okay. Now, and we also talk about, we're always thinking about kind of main campus, but do we have other locations as well where we do the rehab?
We don't for inpatient, but for outpatient we do.
Okay.
So one of the goals for PCH is to start to have more of a presence out in the peripheral community,
Mm-hmm.
recognizing how difficult it is to travel to the main campus.
Yeah.
So while we'll always have a presence of physical occupational speech therapy here at the Thomas campus, we're preparing to open a large and substantial East Valley location and hoping to augment some of our presence on the west side and the north side as well to make it easier for patients and families.
Definitely, and I'm glad you brought that up too, because that's exciting news for us, actually.
Very
so thank
exciting.
you for talking.
Yeah.
I was actually going to kick that over to you, so that's awesome. Great news coming up. So pay attention in the future. There's some big news coming up. Okay, so I think you mentioned a couple of the different therapies. I think a lot of people, when you say the word rehab, I think the first thing people think of is physical therapy. But there's so many other different kinds of rehabilitation, types of therapies there are. What do we specialize in, or what's the gamut of kinds of therapies and rehabilitation that we do in your program?
So on the inpatient side, we have physical, occupational, speech therapy. We do specific swallowing therapy for children who are trying to relearn how to swallow and swallow safely. We have a music therapist. We have child life therapists who provide interactions, distractions sometimes from things that are not so pleasant,
Mm-hmm.
as well as trying to integrate skills that you're going to need to be able to do at home in the community.
Yeah. And is audiology part of that as well, too, or no?
Audiology can be.
Okay.
So we have the benefit of having the audiology program here. So some of our inpatients can get tested if we have concerns about hearing. Of course, there's a large outpatient population that is served by that program as well.
Okay.
And a lot of our therapies are, again, available out in the community or on an outpatient basis as well.
And let's talk a little bit about if someone out there is watching this and wants to kind of get the general sense of, okay, how do you categorize what's outpatient and how do you categorize what's inpatient?
Mm-hmm.
Kind of what's a quick kind of Cliff Note version of how you would differentiate between the two?
Well, inpatient is usually designed either for children who have suffered a new disability, perhaps they've had a surgery or a tumor or an accident, and they need very intensive services in order to even be ready to be home safely.
So that inpatient means they're here and they're staying for a while.
They're here and they're going to stay for the purposes of providing fairly intense therapy services. These are children that we expect that over days in short periods of time are going to be making rapid changes.
Okay.
And we need to prepare them and train their families to go home.
Mm-hmm.
On an outpatient basis, many of the children from an inpatient program then move to the outpatient world to continue to work on their skills. But there's also children who have grown up with disabilities who may continue to receive therapy in the outpatient setting.
Yeah.
And then we also use our inpatient program for things like surgeries that have impacted a child temporarily.
Yeah.
So they've either had extensive orthopedic surgery and they went from being able to walk to being down for 6 or 8 weeks of
Wow.
recovery,
Yeah.
and now they need to get back on their feet, or other types of interventions that have made a big difference in that child that we think we can capture on an inpatient basis.
And I think one thing that is important too that I read as I looked through the site, and it's pretty amazing too. It's not just, you're not just treating the child in many cases. A lot of this is getting the family to learn how to work with that child in these new situations, right? These new diagnoses, these new, like you were just saying, walking to not walking and then having to back to walk again. The family's a big part of this, right? And how do you guys work with the families as well?
We work with the families all the time. Families, of course, can stay at the bedside in all of our units at PCH. But more importantly, we have them in the therapy sessions as they can. We set up training times for parents who may have to be at work. And what we're trying to do is allow them to enable their child to do the most for themselves, but at the same time remain safe, and also educate them about what to expect as time goes on.
Yeah, kind of the chronology of how things are going to play out,
Right,
basically. Yeah.
exactly.
So one other thing that kind of popped out as I was looking and creating the questions for today is the customization that you guys offer. So obviously, therapy and rehabilitation is not a one-size-fits-all. So talk about kind of how you guys approach every patient, and every patient's different, basically, right?
Right, they are, and it starts with understanding what the diagnosis is, understanding what the expectations are, whether that's from my perspective as a physiatrist or rehab doctor, but also including the perspective of the other physicians who may be involved in the care. On an inpatient basis, we set up a treatment plan, and we conference weekly, and we meet with the families as a part of our team, and we talk about where are we at, how many goals did we meet this week, how many are we going to meet next week, are we on target for that estimated discharge date 3 weeks from now.
So it's like a progress report.
So it's like a progress report, exactly. On an outpatient basis, what we try to do is take in all the factors. Is there a planned orthopedic intervention? Who's prescribing this medication or that? And then try to coordinate things so that the therapy that children receive makes sense. Because if you have an upcoming procedure, you're going to want to put all your energies after that and not necessarily before that.
Yeah, that makes sense. Let's talk about how the program, how rehabilitation program works. It works very closely with our Cerebral Palsy and Pediatric Movement Disorders program. It's a big mouthful, but it's at Barrow Neurological Institute at Phoenix Children's. But they're very integrated. So how do they work together? How does the integrated treatments work together from those programs?
So what our goal is right now is, again, to bring physicians together who may overlap in the care of a given patient and come up with some type of rational treatment plan. So there's lots of treatments out there now for spasticity or high muscle tone, different types of movement disorders. But which one should you do first? Which one should you do second? Which one would be best for a given individual? And what we try to do in our complex tone clinic is evaluate the patient, talk with the family about their goals, throw in the goals that we have as physicians, whether it's to preserve the integrity of the hip joint or improve flexibility or improve the quality of walking, and then come up with a treatment plan that makes sense for that individual patient.
And we do, we're into research for cerebral palsy here too, right? And so, and how does that kind of work into the whole rehabilitation or therapy program that we have here?
Well, I think the advantage we have is that we have the structure to be able to do a research project on certain type of therapy intervention and be able to have those children have therapy in our department, monitor their progress, see what that intervention was like, whatever it may be. The other advantage we have is the more we see children collaboratively and in a multidisciplinary setting, we can draw on populations of children so that we can be able to report our outcomes. So if we're doing more of a given procedure, we can then look back and say, this is how the last 20 or 30 or 50 or 100 children did following that procedure.
So using data, basically.
Using data.
Yeah, that's
right.
amazing. We had talked before, and I think you were excited about a procedure, the selective dorsal rhizotomy.
Right.
Let's talk a little bit about that. That's specifically or most commonly for cerebral palsy, but for others as well? And then kind of talk about the history of it. We had it, and then we did, and now we have it again.
Right.
And then the other part of this question is, it's a long question, how does the rehab kind of work with that procedure? Because the procedure is very quick, or not quick, but it's the first part. Then there's that whole back end of what happens after that procedure. Let's talk a little bit about that.
So the selective dorsal rhizotomy, yes, is primarily offered to children with cerebral palsy, but also related conditions. It's a surgery that's designed to eliminate or markedly reduce spasticity in the lower extremities. So for some children, they may have actually had a spinal cord injury. For some children, they may have had a brain injury. So not everybody comes to it with a diagnosis of cerebral palsy, but the majority of children in the country who have it have cerebral palsy. Once the neurosurgeon has performed the surgery on the nerve rootlets at the tail end of the spinal cord, and the spasticity is reduced, we now have to embark on a very extensive rehab program. So we're taking a child who may have learned to move and walk with stiffness and lack the flexibility they need, and they may rely on holding on a walker or crutches. We take away that spasticity, and now we have to work to stretch out the muscles, regain the flexibility, work on strength, and then relearn how to move with a better quality of movement. So that starts 3 days after surgery. On the inpatient rehab program. That's often a length of stay of 3 to 4 weeks of intensive therapy, but the outcomes can be dramatic, and then continued therapy in the community or wherever they can get outpatient therapy to further refine their ability to walk and move. And the reduction in spasticity, as far as we know, over 25 to 30 years has been reduced. This is a procedure that is very common in most children's hospitals. It's a procedure that got started in the late 80s.
Oh, wow.
And became very prevalent in the 90s. But it's dependent on having good neurosurgeons who understand how to do the procedure, why we do it, and are integrated with the rest of the physician team, including rehab. And so there was a period of time where there really wasn't a lot of that procedure being done here in the Valley. And now we have Dr. Taryn Bragg, who's come with an expertise in this area. And so now we're once again offering this on a regular basis to the right selected patient.
And they have you afterwards, which is again your team.
And they have us,
which is the
for
best,
all the
right?
rehab. That's right.
That's
right.
amazing. So, we're getting kind of towards the end of the questions that have the very specific questions. And again, don't forget, you can email us, you can put a comment in there, and we'll get to it as soon as we can. But I want to finalize by asking you, I know one of the things you're excited about is the kind of branching out, as you said, to other clinics and things like that. But what most excites you about the work that you do, and kind of where you see our program going in the future?
I think the most exciting thing is that we have all the specialists we need, and we have the structure, and now we just need to put it together so it's easy to access by patients and families, and to be able to offer all of the state-of-the-art interventions that we have, not just selective dorsal rhizotomy, but intrathecal baclofen pumps and botulinum toxin injections, and not just do it randomly anymore, but really with a thoughtful process. Who's the best candidate? When should it be done? And we'll use our data and the data around the country that we collaborate with to sort of pull that together and be able to be a little more specific and prescriptive about what we do.
Yeah, and I know we centered a lot around movement disorders, and we talked a lot about cerebral palsy, but just to kind of finalize it, are there other programs that we work with within Phoenix Children's Hospital that require regular therapy or rehabilitation, not just neuro and not just those movement disorders?
Sure. Well, even orthopedically, you know, sometimes people have extensive orthopedic surgery, spine surgery. On our inpatient rehabilitation unit, we take care of children who have undergone brain tumor resections and may have some residual deficits, weaknesses, trouble talking, things like that. We have therapists who staff some of the clinics here at PCH, such as the Down syndrome clinic and other clinics that are available. So our therapists are involved in a lot of different areas, and as physicians, we're involved in just about every type of diagnosis that would cause someone to need rehabilitation services.
Yeah, so you guys are basically everywhere.
We're everywhere.
So after the surgery, this is who you see, because they will get you back on your feet or do the best they can with it, right?
That's right. It's the goal.
That's exactly right. So that's about all the time we have. What I'm going to do is I'll let you guys know about the next Phoenix Children's Live. It is actually holiday safety tips. So it's from the Center for Family Health and Safety, and it's hosted by my colleague Riley O'Brien. And that'll be this Thursday, the 14th of December at noon. So hope to see you then. Thank you again for doing this. I really appreciate it. All right. Happy holidays. Take it easy.